All right, good afternoon. Give everyone a few minutes to kind of get logged in here. Hope everyone's having a good start to their Friday and exciting weekend plans. Hopefully the weather holds up for us. Let's see here. Should I just get started? What do you think? Yeah. All right, so I'm going to jump into things here. I'll be answering questions at the end if you want to put them in the chat box as we go. If something's really relevant to what I'm talking about, I'll try to answer those as well. But when we're talking about breast augmentations, this is the most common procedure I perform, one of the most commonly performed procedures nationwide as well. Almost 300,000 are done every year with very high satisfaction rates. And the nice thing about it's also very quick surgery, with relatively quick recoveries as well. So. And there's also a lot of kind of things to be aware of it, and this will kind of touch on a lot of that. So who am I? I'm Dr. Daniel Butz. I'm a board-certified plastic surgeon. I've been at Quintessa for 7, almost 8 years now, since I've finished my residency and fellowship. And my practice has really become very focused on just breast and body aesthetics. So I do a lot of breast augmentations, lifts, reductions, a lot of tummy tucks, liposuction, but really just focusing kind of below the neck, which allows me, in my opinion, to kind of really be kind of more specific and kind of nuanced in some of those results. So what is a breast augmentation? This might seem kind of silly. It's very commonly understood, but breast augmentation is any cosmetic procedure to enhance the size and shape of the breast. Most commonly using breast implants. We'll talk about the different types in a second. Fat transfer is an option, but there's a lot more variables kind of in store in terms of how much fat we can get safely. We don't want to be too aggressive in creating lumps and bumps, how much fat we can put in, and then how much sticks around. So I think it's best for patients who kind of want that liposuction result as the primary goal and looking to kind of accept a little bit more variable volume enhancements, whether it's a half cup size and maybe a half cup size, depending on what you're starting with. The most common reasons I'm seeing patients, there's kind of a few different ones. The most common is probably just volume loss after breastfeeding. I think frequently patients come in saying, I never thought I'd get this done. I really liked my breast before breastfeeding or just pregnancy. They've lost volume and kind of want to restore that. And sometimes patients have never really developed a lot of breast volume and want to create better contours or shapes. Sometimes there's asymmetries they're trying to improve. And a lot of it really comes down to boosting your confidence, how you fit into clothing, swimsuits, are kind of a lot of the key things people often talk about. So in the types of implants, during the consultation, we often show you them, you can feel them, but there's 2 main types, silicone and saline. The silicone, often referred to as the newer gummy bear implants, these are all cohesive gels. So the silicone inside is cross-linked, which gives it more shape and stability. Back in the 90s, they were much more viscous and kind of liquidy. And if they did rupture, it could kind of leak out of the capsule. With these newer gel types, they create more shape, more form. And even if they do rupture, it all stays in place, which is great. Tends to feel more natural, move a little bit better with your body, which again, for a lot of active lifestyles, patients really tend to like that a lot. Saline implants have a silicone shell and then are filled with salt water. Some people argue that maybe the benefit is that if they rupture, well, that's really the main benefit, because if they deflate, then it's ruptured. There's also a little bit more urgent situation. They also tend to be more firm and kind of lack the structure that a silicone implant has. So more likely to see rippling or kind of visibility, and you just feel firmer as well. There's a lot of different shapes of the implants, profiles, how much projection. People often refer to kind of there's low, moderate plus, full, demi, extra full. All of the companies have kind of different terminology for this, but it really comes down to kind of how they're packaging that silicone, whether it's more width or more projection, to allow us to have more customized options to fit your individual anatomy. We've kind of stopped using the traditional teardrop shaped implants because they required a kind of more aggressively textured surface that had the very rare case of kind of breast implant associated anaplastic large cell lymphoma, which is a mouthful. Essentially is an overimmune response to the surface texture. The newer Motiva implants have a kind of a very tiny texture, which had no case of that in 14 years. So very different situation. But again, during the exam, you get to feel and kind of see these differences. And a lot of it comes down to picking the right implant for your anatomy. People often focus on the CC volume, but the width, the projection, all these things are almost more important than just that. Incision options. So there's a few different options. I tend to be biased towards that incision in the crease underneath the breast called the inframammary incision. It tends to hide really nicely in that fold. There's a lot of good data, and it's kind of boring stuff, but it has lower risk of bleeding issues, sensation change, and capsular contraction. Because you have better visualization, you can really see the pocket you're creating much more effectively. And most revisions are done through that incision as well, if and when you need that. So that's one of the main reasons I like that incision, and they're often hard to find after a year or so. The incision around the nipple, periareolar, almost the kind of lower portion of the nipple, used to be more commonly used. Again, the data kind of started showing there's a higher risk of capsular contraction because you're going through the breast tissue, which tends to have a little higher risk of that. It can heal really well, but when it doesn't, it stretches and can distort. So I'm not a huge fan of that incision unless someone already has it present. And the transaxillary incision, in the main appeal is that there's no incision on the breast, which is quite nice. But you're kind of further away from creating that pocket. So there's been again, higher risk of bleeding issues. You can't see things as well. More issues with implant lateralization, sometimes bottoming out. And you can't put in the internal bra mesh that I like to use as well. So some limitations there. But there are options depending on again, what your goals are. The implant placement is a really big thing that's changed in the last few years. Again, obviously, I think, was it Kylie Jenner recently just posted about her surgery being half above, half below, which I've been getting a lot of questions about. But during the surgery, we create a pocket for the implant. Most commonly, we've been putting in below the muscle called dual plane. That's kind of the half above, half below. I don't know if you can see my pointer here, but we often release the lower portion of the muscle so that the implant sits in the right spot. So that's what Kylie Jenner was kind of referring to, half above, half below, which has, again, been the most common way of doing it for probably the last 15, 20 years. Going completely underneath the muscle tends to make a very high riding, tight implant. Activating the muscle tends to be a little bit more discomfort. There's been a shift in the last few years to do what we call subfascial, so putting it above the muscle. And not disrupting the muscle at all. People often referring it to kind of as a muscle preservation. With the newer, more cohesive gel implants, the more gummy implants, you can still put it above the muscle and it can still look quite natural. Back in the 90s when we were kind of mostly using saline implants, which are much more visible, or the less structured silicone, this wasn't quite as viable of an option. And one of the more historical issues was that gravity time with kind of more stretch. If you're just relying on your skin, utilizing these internal bra meshes helps to support that and limit that potential for stretch. So I tend to again really talk to each individual about what their goals are, their concerns, and kind of figure out what might be the right solution for you. Again, if you want a bigger implant, you don't have a lot of coverage, above the muscle probably isn't a good option. But smaller implant, enough tissue coverage, you can still look very natural and kind of allow you to do push-ups and things just fine. And the other thing below the muscle is a little easier for mammograms still, but with newer technology, MRIs are often being incorporated with that as well. So the surgery itself, during the consultation, we kind of go over a lot of the general instructions, expectations with that. Sizing, we do it kind of take 2 different visits to size to make sure we're getting that size just right. We use 3D simulation as well. It's a really important part of that. The surgery itself is typically just 1 hour, sometimes even less. If we're doing a lift, maybe an hour and a half. But just very tiny incisions, 3.5 to maybe 4.5, depending on how big that implant is. So again, that's less than 2 inches, less than 1.5 inches for smaller implants. The first week, you're taking it kind of easy, but you don't need to be frozen and stuck in bed. You're up doing most of your regular stuff, just kind of being cautious, doing things a little bit slower, wearing supportive bras. And between 1 and 6 weeks, you can long walks, light stuff. We can often even tell patients that are on 3 weeks you can do some kind of light arm curls, but really avoiding any strenuous activity, getting your heart rate up too high. that can make things swell more, things like that. So most of the time they're quite straightforward and smooth recoveries. Most people take pain meds for just a day or so, and then ibuprofen, Tylenol. But yeah, we kind of go over a lot of that stuff kind of at during the consult and at the pre-op visit where we verify the implant size and all those details. Safety, obviously, is a really important thing. We like to be prepared. All surgeries do have risk. This is a very low kind of complication surgery, but bleeding issues can occur. You can develop hematomas. With proper surgical technique and good early post-op care, that risk is less than 1%. Capsular contraction, that's when the scar tissue on the implant gets too tight. There's a whole host of these newer no-touch technique protocols, where there's like a 12 or 14 steps we apply during surgery to ensure that there's really no touch, essentially. So nothing touches that implant using this Keller device. That's really reduced capsular contraction rates from what it used to be, 20 to 30%, 20 years ago, to now, in my practice, 0.8%. So we take a lot of precautions to really reduce that dramatically. Implant rupture, again, the newer implants are much more durable. One of the more common causes for ruptures years ago were kind of fold flaws, where the implant, again, they have less structure, would kind of fold on themselves. The newer implants really resist that quite a bit. So newer rupture rates at 10 years are as low as 3 to 6% for these newer devices, which is fantastic. Saline implants, their rupture rates are still about 15% at 10 years. But sometimes I see patients with 30-year-old saline implants that are totally fine. But again, it's just important to be aware of that. And with newer, the FDA recommends we check on these implants with MRI or ultrasound. We can do ultrasounds here in the office for free. So we often encourage you to come in at the 5 or 6 year mark to kind of take a quick look and make sure everything's looking good. Infections are essentially non-existent. That'd be extremely rare, but in theory is possible. How long do they last? Like I mentioned, again, ruptures are, even at 10 years, quite low. The most common reason for revisions that I see are really just for kind of just maintaining that result. So oftentimes, as you over 10 to 20 years, your body continues to age, your breast change, skin laxity changes. So we're often not fixing a problematic implant, but just maintaining that result. So whether it's a little bit bigger implant because you've lost more breast tissue, or maybe more skin laxity, or tightening up a lift or doing a lift, are kind of the big, oftentimes the driving factors of that revision. And we take out the implants and they look almost brand new. But again, monitoring is helpful to make sure that the implants aren't ruptured, because you're not going to know it. Definitely, it's always important to understand they're not meant to be a lifelong device. At some point, you'll likely need a revision, but they can last a very long time. So these are a few different examples. Everyone has different goals. This patient had breastfed, I think, 2 or 3 children, just wanted to restore some of that volume. So she's 6 months out from a 295. SSM, what that stands for, in different companies and different terminology. It's a smooth shell, soft touch gel is kind of the in-between. I'll talk about that in a second. And then the moderate profile. So in these different profiles or shapes, the same volume can be packaged a little bit differently, but to match her base width, we want it to fit really nicely. That moderate profile is going to give her that a more natural kind of shape. This is the dual plane, so half above, half below the muscle. And we kind of have this internal bra mesh to help support things as well, just to minimize long-term stretch over time. This is above the muscle to SSLP, so low plus, a little bit less projection. A little smaller implant. She was younger, very active, didn't want to disrupt the muscle, and had good tissue in what we call tuberous breast, a little bit narrow breast tissue and wide cleavage. So going above the muscle really allowed us to maximize her cleavage lines. And even with a less profile implant, she gets good projection. Again, also having that mesh to support things. Motiva is a newer implant that came out about 6 months ago. It's a very nice implant. It's been in Europe for 14 years. They have 2 different gel types called ergonomic and round. The ergonomic upright looks a little bit more like a teardrop shape. So this patient can lost volume after breastfeeding. This is a subfascial, so above the muscle augmentation with the mesh. It has a fairly natural slope here. And we talked about doing a little lift. Your nipples are a touch low. She didn't want the scars. Not everyone needs a lift. It's always just important about understanding about what that outcome's going to look like. And then different profiles, they call theirs mini, demi, and full. Again, it all comes down to having the right width for your chest. We get nice cleavage lines, nice shape, and very quick, easy recovery. Your 4-month, you can similar kind of stuff here, but that 3, 10, 2, and 5 are often kind of fixing little asymmetries. So the right side is a touch smaller than the left, but again, good shape, projection. Again, little incision in the crease, you can almost barely find those typically. And cleavage lines are always really important. And you have, a lot of that comes down to your rib cage and kind of how those implants sit. Another younger patient again had kind of what we call constricted breast because your nipple to fold distance is quite short. We had to expand that a little bit, and nipple asymmetry, but didn't want to again extra scars to do that. So we accept those little things. Here 415, 450 to balance off the little volume difference and improve her shape. Again, here's that a diagram of the internal bra mesh and how we put it in to kind of help support that outer pole to try to maximize kind of your cleavage and minimize stretch and potential for lateralization. A couple more examples, again, 450, 485, again, little differences or asymmetries, again, fitting into a swimsuit. We often combine these things with tummy tucks or liposuction. There's a 6-month, 345. And obviously not everyone wants implants or wants to be bigger, so sometimes we're just trying to focus on improving the shape. So here, she was just a little bit low and kind of square and boxy. She wanted things lifted, again with the tummy tuck, but again rounding things out, nipple more centered on the breast versus down to bottom. Her tattoo provided a nice kind of landmark of how much lifting was provided. So lifts are all about shape. Implants provide more volume and structure. Reductions, make things smaller. Another example of just a lift, trying to improve that shape and how things fit in clothing. We're often utilizing implants with lifts to provide a little bit more volume. There again, a lot of patients are now losing a fair amount of weight with GLP-1 inhibitors. So here we get extended tummy tuck, 360 lipo, augmentation with the lift, 375, again, utilizing that mesh, finding a really nice outcome there. Another little, 445 dual plane with mesh. Again, everyone's different, has different goals, but it's all about understanding what your goals are and finding that right implant or right procedure that's going to accomplish that for you. So these are some of the frequently asked questions. Again, if you have other questions, feel free to put them in the chat, and I'll try to answer those as well. Number one, will I lose nipple sensitivity or feeling after surgery? This is a common question we get, and it's an important thing to be aware of. There's always a chance that nipple or nerves could be damaged during surgery. There's certain areas that we know those nerves come out, and we do our best to try to preserve those. Everyone's anatomy is a little bit different. So early on, it's often quite common to have a little alterations, but that typically does improve pretty quickly within the first 4 to 8 weeks. A lot of that comes back. But long-term nipple sensation loss, let's say up to 2 years, is maybe 2%, so relatively low. Can I go braless after getting implants? So I look, despite utilizing internal bra meshes and all these things, they're nothing's bulletproof. So I always encourage patients to look at bras kind of like a retainer after braces. We want to help stabilize things, fight gravity, help your tissue out. Not that you have to wear a bra all the time, but trying to wear one as much as it's convenient. Going totally braless afterwards just increases the risk of gravity taking over and aging taking over a little bit faster. So what happens if I get pregnant or gain or lose weight? So pregnancy does change your breast quite a bit, especially breastfeeding afterwards. And a lot of it's through that breast volume that's kind of covering up the implant. So the implants are often quite stable. But you might lose more breast volume afterwards or have a little more skin stretch. In my experience, sometimes if you have implants when you're younger, then you get pregnant, have one child, and things often bounce back quite well. But it's the second or third time that there's just multiple kind of episodes of stretching, expansion, that you might be a little bit more prone to having a little bit more laxity and maybe desiring some sort of revision to tighten things up. Gaining or losing weight, tends to be a little bit less dramatic. It kind of depends on where where you individually, your weight kind of goes. So they might get bigger, they might get smaller, but normally it's not too dramatic. The cost, I don't know exactly. I think it kind of depends on each individual. I think their average augmentation is anywhere between like 8,700 to maybe, if you use the mesh, or a little less than 10,000. That includes, the newer implants. A lot of people like to advertise their price for their saline implants, which is quite a bit less, but we want to get you the right surgery, the best kind of long-term result for you. But during the consultation, we give you an exact quote so that you understand all the components that go into it, and the implant you choose, the mesh, if I think you benefit from that, or you're going to use that as well. Let's see. Can I still breastfeed after breast augmentation? Yes. So typically we're going below the breast tissue in either scenario. So we're not really alterating that at all. The nipple is still connected to all the breast ducts. So that should be totally feasible to breastfeed as well. And implants do not compromise or change the breast milk or anything like that either. Can implants make me look too fake? So this really comes down to implant size. So again, during the consultation, discussing what your goals are, and frequently, I look at not just what your general cup size goal is, but we look at your anatomy, the width of your chest, how much tissue you have to camouflage the implant. So if you have decent breast volume but just want to be a little bit bigger, you can often, that can look very natural. If you have very little breast tissue, you want to be quite big. If you're going from A to D cup, that's going to look a little bit more enhanced. So you can take the same 300cc implant, and on someone who's 5 feet tall, 100 pounds, it's going to look very different than someone who's 5'8", 130, whatever that might be. So there's very good ways to figure out how not to make you look fake if that's what you want. But again, everyone has a little different goals in that. And can you combine augmentation with other procedures? Absolutely. We do this all the time. Commonly referred to as the mommy makeover. Really, we can do these very efficiently and safely is the key thing. So a tummy tuck with the breast augmentation can take less than 3 hours typically. If you're doing extra back lipo, maybe 3.5. So I like to keep surgery length to less than 5 hours, maybe 6 hours. So for occasional things, but so hopefully that answers a lot of the kind of common questions. So we have one question here: when a lift is being done along with implants, do you always have to cut and move the nipple? How often does necrotic nipple happen? The most common, if we're trying to reposition that loose skin, kind of the drooping or kind of ptotic nipple position, making incisions around the nipple are really kind of necessary to reposition things. There aren't really techniques. There are very rare situations where you just remove tissue from the fold, but oftentimes that means the nipple's too high. When the nipple is left attached, so we're not removing anything, and the chance of a nipple not healing well is, unless you're a smoker or diabetic or kind of medical issues, extremely low, like less than 1%. So knock on wood, I've never had that happen with an augmentation lift. But certainly something to be aware of and kind of planning things properly for sure. Let's see here.
We do have more questions. So next to the chat box.
Am I looking at it wrong? Oh, question box.
Mm-hmm.
All right.
We have
A lot of questions. Great. So is the type of location of a scar something a patient can choose, or is it typically determined based on the specific approach? So implant placement, I tend to recommend the inframammary fold incision because of all the benefits. If someone really has a strong feeling about one or the other, we can talk about that. But in the lift incision, sometimes we do lifts just around the nipple versus that vertical incision, and the length of the incision, kind of the anchor approach in the bottom, kind of depends on how much lifting we need to do. So smaller incisions tend to lift less. So it kind of depends on how much lifting is going to be necessary to get you the best result. Normally those incisions decrease height really well, and that vertical one does fade nicely over time. Is there a weight limit? So for just a breast augmentation, where there's not a strict limit. Ideally, use BMI as often a rough cutoff. Less than 32, around 32 is typically safer for elective surgery, but it's not quite as strict for that. Go for consult in Delafield. I see consults in Delafield in our Brookfield location. So certainly I'm available in Delafield. the extra mammograms or imaging done prior. So this is kind of case by case. And NA, again, if you're 32, I don't think you need to get a mammogram. If you're 40, you've never had one, it's not a bad idea. But depending on family history, we don't require you to go get one. But try to talk to your primary doctor about making sure that you have proper screening. I think the biggest thing is just doing regular self-exams is probably the most effective. Just general screening tool. Obviously, mammograms are an important thing as well, but knowing what your breast feels like and how it changes is really helpful as well. Are there any common factors that can lead to early implant rejection or complications shortly after surgery? Again, fortunately, early rejection or infections are extraordinarily uncommon. So I wouldn't say there's any really common factors. Again, the breast implant illness is kind of that vague association of implants to various autoimmune-like symptoms, which sometimes people refer to breast implant illness as kind of being an implant rejection. If you really kind of look deep into this, it's a pretty vague association. Look at all comers at risk of associating that kind of the symptoms are probably 0.5%. So despite it gets a lot of attention online and on social media, it's extremely rare. Most patients at 10 years are very satisfied with their implants. 95, 96% of patients are very like them and would do them again. So fortunately, again, those sort of kind of early complications are extraordinarily low. So let's see here. You have breast augments for someone who runs, lifts, or leads a very athletic lifestyle. So often as you're really more active, I tend to talk more about maybe subfascial going above the muscle, but ultimately it comes down to what your goals are. And I've had a lot of patients who get really thin, you don't have any really tissue coverage, and they want a bigger implant. Then you either accept maybe a little bit rounder look, or you go below the muscle, and then it's kind of a trade-off. Do you want to again kind of maybe lay off the chest workouts, but you can still do everything else. I have plenty of patients doing CrossFit, lifting hard, doing all this stuff with implants below the muscle, and they can do it all just fine. Early on, you want to just kind of modify so that you're not having that muscle push and potentially stretch things out. But if you're like, I really want to, if you want to be doing all the your pectoralis workouts without any limitations, I can kind of guide you in what a appropriately sized implant would still give you a natural result based on your anatomy. But it's just all about kind of matching that to make sure it fits your frame, your anatomy, your goals, and lifestyle for sure. Does having subfascial breast implants make it more difficult to perform and interpret mammograms? Yes, it is a little bit harder above the muscle versus below the muscle. But again, they're often utilizing ultrasounds and MRIs kind of fit that in. So again, it's all about looking at in your family history, your risk factors, and making sure you're going to aware of those differences. You're still able to surveil things. You just might need to do a few extra tests. A lot of patients who have small, dense breasts often need to do MRIs anyways, because mammograms aren't very effective in those situations either. Swimming restrictions. Typically, you want the incision to be perfectly healed, which normally it looks like almost perfect at 3 weeks, but we say maybe wait till 4 to 5 before you're really submerging. Normally it's pretty little incisions that heal quite well. Can you talk a bit about reductions? Uneven, want to introduce one in size, and concerned to have the nipples more even with each other. So a reduction, like those lift examples I showed, the breast lifts or mastopexies, very similar kind of concept to a reduction, but the reduction we're just making things smaller. And again, oftentimes if we're asymmetric, we don't want to have implants, we'll lift the smaller one and then reduce the larger one to try to make those match better. Certainly trying to get the nipples more even, and the volume closer is a huge part of that, and a very common thing we do as well. So I should have included some reduction examples in here, but for time we kind of left out some of that. Martini glass breast size. Need a lift? Do I have to have an implant placed? Do not wear bras that much unless going out, or is wearing a bra a must after a procedure? So if you just had a lift and you have smaller breasts, implants are not, or lift bras are not as necessary. It's all about bras are kind of trying to help fight gravity. They don't, there's been studies looking at, do they truly prevent drooping or ptosis? They don't necessarily. But so if you just do a lift, there's not a lot of weight to them, bras aren't probably as beneficial. So I see a lot of patients who, especially there's been a trend to kind of smaller, perkier, tinier breast, and just want things lifted and tight so they're not, having the loose skin in bras or kind of having to worry about, things kind of sliding out of bras. So just a lift in a smaller breast can give you, again, kind of a nice perky result. Then you don't need to wear a bra for sure. If there's kind of, again, anything about less weight to the tissue is kind of the key thing. So let's see, how far am I booking out and what locations do I work at? So again, like I think I mentioned, I see consults at Brookfield and Delafield. We do offer virtual consults as well. We have that Chrysalix 3D simulation software, which you can send in these photos. We can kind of do some simulations of the augmentation that you can look at. But it is good, I think, to obviously see me in person before surgery at least once to size and make sure we're kind of making just the right plan for you. How far I'm booking out? It's a great question. Consults, normally summer slows down a little bit. Things have been pretty busy this June. Consults are probably sometime late June and July for sure. The next few weeks are pretty swamped. But if you call, they can certainly give you that exact information. I just don't know it off the top of my head. So recovery, again, kind of, if it's just an augmentation we're doing, if we're going above the muscle, it's often, pretty straightforward. You're a little sore, taking it easy with your arms, but not frozen. They often encourage us to do things a little bit slower. My overarching kind of guideline is listen to your body. So, again, test it out, make sure it's not tight or funny. Don't do things, again, slower so you can kind of respond more appropriately. Wearing support is kind of also helpful, obviously. But I want you up and moving. I don't want you necessarily stuck in bed. And so again, pain meds for maybe 1 to 3 days, ibuprofen, Tylenol after that for maybe another week, icing. And a lot of people just biggest complaint is just tightness. Just feels tight. The skin's tight. Sometimes people come in at 1 week like, are they ever going to soften up because they're just kind of really firm from the swelling? And absolutely, as the swelling kind of settles down, as things kind of, that often referred to as drop and fluff, they start to feel more natural, move more naturally. So it definitely takes time for that. We want things pretty tight right afterwards. We know they're going to loosen up. If we make it too loose, that pocket's too loose, that's not good for long term. So that's really important as well. But again, the tape, if it's just an augmentation, tape's on for 1 week, we take it off. Incisions, again, tiny, often look perfect at a week. If it's with a lift, we leave the tape on for 3 weeks. Just protects things, and again, we take it off then. And again, most of the sutures are dissolvable. With lifts, sometimes they put some little superficial, little tiny blue ones in certain areas, and we take those out at the 3 week mark. And then again, exercise and activity, you're often doing most of your daily stuff within a few days. Light activity after about a week. And then exercising high intensity at 6 weeks. So does anyone come back after surgery and say they do not like the implants, they really want the aesthetic, but I'm concerned about how they will feel, and I feel okay with them? Would it be going with a very small implant, but I don't know how they will feel? Most of the time, people kind of forget they're there after 2 to 3 months. Kind of it's like feeling like a part of you. Sometimes there's kind of some implant awareness early on that kind of feels weird. But again, that's often just the first 2 to 4 weeks. Then it slowly just kind of starts becoming your body, your brain gets used to them being there. So I haven't had anyone kind of express that beyond maybe 2 months. Especially again, smaller implants, more breast tissue, they often disappear. You can barely tell they're there. If you less breast tissue, a little bit bigger implants, sometimes you can feel it a little bit if you're trying to. But I often tell patients that's normal. It all comes down to what you have to camouflage it. But if you're casually feeling the breast, they often feel quite natural. But yeah, I mean, they're again, very popular procedure with very high satisfaction rates. So I haven't really had anyone specifically with that concern. How soon after subfascial do people feel fine returning to normal life work? Again, depending on the size and your situation, what you do for work, sometimes it's just a long weekend. So maybe 3-4 days, you're pretty good to go. You're off the pain medications after a day. able to drive, within 2 to 3 days, pretty commonly, even below the muscle. If you have a more active job, maybe you need a week, but normally it's not too substantial if you can kind of just modify what you're doing a little bit. What would make you recommend the Motiva Mini versus Demi for a natural look? So this really comes down to your anatomy and your goals and what volume you want. So if someone wants a smaller implant, depending on their base width, then let's say someone wants 230, but their base width is a little bit narrower, then they might need a Demi to make sure it fits appropriately. I don't want to put a wider implant in, which would be the Mini, and give them too much width. So they can both look very natural, again, depending on how much tissue you have to kind of start like a broken record here, how much tissue you have to cover it up, and what your anatomy looks for. So I look at the profile, I kind of let you pick your CC volume, and then I find what profile is going to fit you and make that recommendation. Sometimes there's an in-between. You can kind of go both ways, and I talk about, what one might look like more than the other, but we're often kind of splitting hairs, like, quarters of a centimeter differences between those two. Are there any medical conditions that might increase the risk of adverse reactions? Again, the big things are smoking is kind of bad for any surgery. So that can make things not heal well, increase risk of capsular contraction. And then, really diabetes, obviously that can also impair how things heal, so poorly controlled. Then if you require a blood thinner for any reason, that can make the surgery itself a little bit riskier. But even if someone has a history of blood clots, we can use Lovenox afterwards. There's ways to get around a lot of that, unless you need to be on it. Then we need to think, is this worth doing the surgery? But those are really the big things. Is the surgery booked out far at all, or is it something that could be done before the end of the year? Yeah, we have our own surgery center here. I operate 3 days a week, so breast augmentation, we can often fit these in. If it's just an augmentation, a 1 hour surgery, kind of fit that in places pretty easily. So certainly before the end of the year should be pretty reasonable. Are there usually any restrictions for sleeping positions post-surgery or long-term? So normally the first few days, I kind of have you sleep a little elevated, just helps take the weight of them off the touch. Laying flat off, just kind of increases the pressure of the implant. Side sleeping normally is fine after a couple of weeks. If it feels okay, it's kind of, listening to your body. If it hurts, maybe don't do it, but I don't mind the implants being pushed towards the cleavage lines. I never want them being pushed away or outside. Stomach sleeping isn't great for implants. So I try to encourage you not to do that for at least 6 weeks, and then consider obviously definitely wearing a bra and maybe padding things a little bit differently if you're kind of always a stomach sleeper. Let's see here. Can you talk about fat transfer with an aug? So in some situations you can include fat transfer with an augmentation. If we're trying, that tends to be best for trying to narrow kind of a wide cleavage gap. So someone has really naturally kind of wide cleavage, but if there's you can just feel nothing but bone and there's no tissue there, putting a little bit of fat there can help soften that out a little bit, especially let's say you're subfascial, or you want to be subfascial, you don't have a lot of tissue, you can kind of put a little fat in there to help camouflage the implant a touch. So that certainly is something you can do as well, and that tends to be more effective than just doing fat transfer, which again is a good option for some patients. But it all comes down to what your goals are, and trying to make sure we can achieve those. And with fat, it's just more of those variables that we're kind of working around. But complementing it with an implant is a little bit more guaranteed of a result. Yeah, I think that may be it. I really thanks everyone for all your great questions. Maybe there's more. Oh, wait. Just had a lift in my double Ds, so they did go a little smaller. But I lost a lot of weight, and they were much smaller. Our implant's the best way to go. Yeah, certainly if you had a lift and then lost weight and they got smaller, implants are certainly the most effective way to make them bigger again. And yeah, that's certainly, sometimes we've seen someone had a reduction 20 years ago and then things have changed, they got smaller, they want a little bit more fullness, they're not maybe as big as they used to be. But it's pretty straightforward to kind of put an implant in and fill out that now loose skin or kind of restore that volume. Maybe modify the lift a little bit if necessary. But yeah, so that can definitely be done kind of afterwards for sure. So yeah, thank you all for taking the time out of your lunch to participate. Hopefully this answered a lot of your questions. I think, let's see, what's the next page? So yeah, if you want to schedule a consultation, call this number. They can give you all that information. They can probably give you better price ranges too, and scheduling kind of timelines. They're fantastic and have all that information at their fingertips. We are doing a little raffle, so someone will win a $500 off their breast augmentation procedure. It's a little perk for participating. We'll announce that at 6 o'clock tonight. So good luck to you all, and hopefully I'll meet you in person someday. Have a good rest of your day. Thank you.